Morning, everyone. This is Kathy Bush, and welcome to the DandleLION Medical Webinar on the NeuroBehavioral Assessment of High-Risk Infants. We're so pleased to have Bobbi Pineda as our faculty presenter today, and we also have Kathy Randall with us to provide technical support and to assist with answering questions at the end. So a little bit about Bobbi. Bobbi is a PhD occupational therapist. She's a research scientist with an interest in developing interventions that can optimize neurodevelopmental outcomes in high-risk newborn infants, specifically infants born prematurely. In addition to her research experience, she has more than 20 years of clinical experience as a NICU-based occupational therapist and has been involved in defining and implementing interventions with families and NICU staff to optimize outcomes. The focus of her research has been on investigating the effects of the early neonatal intensive care unit environment on brain development. Bobbi is certified as a trainer on the NICU Network NeuroBehavioral Assessment and is certified in the use of Prechtel's General Movement Assessment. Understanding the unique qualities of infant assessments and assessing the psychometrics of early neurobehavioral assessment is an important part of her research. So Bobbi, we're going to turn it over to you.
Thank you, Kathy, and thank you so much for the opportunity to talk today, to talk about something that is a very large part of the research that I do, and I always love to share what I've learned along the way and also learn from others as we continue to better understand early development. And also thank you to everyone for joining today on this Friday morning or afternoon, and we'll go ahead and get started. Okay, so the objectives for today are to discuss the purpose of the NeuroBehavioral Exam, to define different assessments available for use with high-risk infants in the NICU, and then to discuss how to administer and interpret assessment results. And of course, we're not going to be able to cover every neurobehavioral tool that's out there. I will try and touch on the majority that are appropriate and available for use with high-risk infants in the NICU, but I'm going to go a little bit more into detail on the ones that we typically use within our research, but just know that that doesn't necessarily mean that there aren't others that are available and out there. So when infants are admitted to the neonatal intensive care unit, they face a wide range of medical complications and also varying amounts of brain injury. Each medical course and the developmental implications that are related to those are unique for each infant. And so parents typically ask either at the beginning of their hospital stay, during it, or maybe even at the end as they get closer and closer to discharge, how their baby's doing. And many times we focus on the medical part of that picture. So we might rattle off whether they've weaned from their O's or how they're keeping their current oxygen saturation levels or what their heart rate is. And all of those medical factors are actually really important in terms of coming together as a cohesive whole to inform a risk for developmental challenges, but they're also very numbers-based. And sometimes we also encourage families to really focus on numbers, which can also be a little bit problematic. Another way that we might assess how an infant's doing is to look at the results of advanced imaging. So we have tools available to us now, including EEG, cranial ultrasound, and also MRI is gaining some traction within the NICU. And so we may rattle off that they had a grade 2 IVH, or they are showing signs of cystic PVL, or that their MRI is normal. And we may relate to parents how the overall health of their baby is based on these findings as well. But what I want to talk about today is really related to infant behavior and how we can really help parents get in touch with the unique challenges that their child has, as well as their unique strengths, so that we can really help foster more parent-child interaction and really inform different things that they can do with their infant to help promote and optimize development across time. So some of the neonatal assessment myths, and I hear these a lot as I speak at different venues, is I oftentimes hear, well, infants don't do anything, so what is there to assess? I also hear developmental functioning cannot be determined until childhood. In fact, some comments that I've heard even relate to that you can't really assess how a child is done after premature birth until they're entering school. That's really when we'll know how everything kind of turned out. Also, kind of going back to the whole concept of infants don't do anything, is that if infants are able to sleep, poop, and eat, that oftentimes they're labeled as really looking great in terms of their development. Also, there's this whole idea of a wait and see, and I think that the whole wait and see idea can be very dangerous as we make recommendations for early intervention following NICU discharge, because what we do is unfortunately miss out on windows of opportunity to really improve development across time. Sometimes there's reason why we might recommend a wait and see approach, but for the purposes of what we do, we're really much more involved in trying to assess what developmental challenges an infant has, and then trying to give targeted interventions based on those findings, and saving the wait and see for really when a child is developing normally and just needs that continuous follow-up from there, or intermittent follow-up. Also, there's a myth of parents and pediatricians always knowing what the infant's deficits are. And, as we'll delve into in just a moment, infant behavior is quite complex. It's not just one thing. It's a whole multitude of different things. And sometimes it takes somebody who has specific expertise in infant development to really be able to find out what the unique challenges are with an individual. And then also parents. Parents are oftentimes very overwhelmed by the whole NICU environment, by being a parent within a tenuous environment. And they might not necessarily know what their infant's deficits are. And, then they also may just resort back to focusing on the numbers. If the infant's doing really well, from a medical standpoint, that's a celebration to a certain extent. And so they might not necessarily know what to look for in their infant's development, and then also what to work on. So what is the NeuroBehavioral Assessment? So the NeuroBehavioral Assessment is a functional evaluation of infant performance. It's to some extent our window into really what's going on in the central nervous system. But it's not really related to just one thing. So whereas an MRI is going to tell you potentially if there's an IVH, the NeuroBehavioral Exam is going to show you the outcome of that IVH, but it's also going to incorporate all of the different things that are going on around the baby. So the impact of the environment, of the brain injury, of medical interventions, and also of any kind of therapy or even parental involvement that has occurred during that time. The NeuroBehavioral Assessment relies on the premise that each infant has inherent capabilities and that these capabilities can be altered by brain injury, disease, or the environment. And then as we'll delve into, it includes an assessment of a wide range of responses. So lots of different things that we can be looking for in our babies within the NICU. The comprehensive evaluation is one of those critical elements to really understand the infant's whole story. So while the medical course that the infant goes through within the hospital is really important and is part of their overall picture, the comprehensive evaluation of neurobehavior gives you insights into what the outcome is of the infant at that moment. So it tells us about self-regulation, attention, reflexes, movement, also how they tolerate positional changes and other challenges or environmental stressors. And then also feeding is one of those things that we work on. It's not really necessarily related to neurobehavior or neurobehavioral assessment, but neurobehavior very much impacts the feeding success of a child. So some of our neurobehavioral assessment truths are that there are valid and reliable tools available to assess during early infancy. The comprehensive evaluation of the young infant can uncover strengths and deficits related to the foundations for later skill acquisition. And those early findings from the neurobehavioral assessment can really inform what targeted interventions are for a baby. I went to a conference a couple of years ago, and one of the neonatologists pulled me aside and said, okay, so you can do neurobehavioral assessment, but are there really targeted interventions for babies? And it's actually quite surprising that from speaking as an occupational therapist, it was a surprising question for me. because it seems like all that we do is very targeted. It's not just generalized, but potentially not everyone understood that, and including this neonatologist who approached me. And then I think most importantly is that the neurobehavioral assessment can be used to guide parents to understand their infant's strengths and their areas of challenge. And really, it's a way to get the parents to get in touch with their baby, to get away from the focus on numbers within the NICU and really to focus on their baby. So behavior and development is really not something that we necessarily need to address after all of the medical factors within the NICU have resolved. And I'll talk a little bit about timing as we move along. But it's really something that we can continue to address in tandem with all of the other things, medical interventions that are going on within the NICU. However, neurobehavioral assessment in the NICU, it's extremely important that we use caution and that also we use the right tools based on the age, the medical status, and also the vulnerability of the infant. There's one of these challenges of that you can't use assessments that are designed for infants later in the first year of life. So the tools that we use for babies within the NICU are very much specific to that time in the early neonatal period. And, of course, we have to use different tools if a baby's at 34 weeks postmenstrual age compared to if they're at 28 weeks postmenstrual age, and then also compared to if they're about to go out the door and they're closer to term. The other part of neurobehavioral assessment is the intense need to just remain sensitive and flexible during the assessment. Sometimes we go in feeling like we're going to be able to do a neurobehavioral assessment, and the baby has other plans. So as an evaluator, just being able to make that adjustment to our plan and come back at a time that's more suitable for the baby if they're not tolerating it. And then the other part is just embracing change. So one of the other comments that I hear quite frequently in regards to neurobehavioral assessments is that they're not really a solid assessment because if you do the assessment one day and then you come back the next week, it could be a completely different outcome that you see. And then also if you see a baby on a day that they're just having a bad day, maybe they had an eye exam and an x-ray, and maybe they, for the first time, were trying all of their feeding attempts by mouth. That could be very different from if they had a very calm day where the mother was involved in holding them most of the day. But I think that that's, again, part of how the neurobehavioral assessment is a great tool because it's going to help inform us on the infant status given all of the different things that are going on with the baby. So knowing when to assess is a constant question as we move forward with our research. And identifying when the appropriate time to assess is definitely something that requires special training and experience with high-risk infants in the NICU. Having a good grasp of stress and approach signals. Well, first, having understanding of medical complications and those interventions that go along with them, so that you know the medical fragility of the baby, but then along with that, knowing the stress and approach signals that a baby might get and how they may go through different stages of development with different stress and approach signals is really important. And then also understanding the vulnerabilities of immature preterm infants and the complexities of engagement in the midst of medical complications. But along with that, there are tools that rely on observation alone. So some tools don't require you to actually do anything physical with the baby. So on those babies who are more medically complex or going through a very vulnerable time, those tools are available where you don't have to do anything. Others can be done when an infant is able to tolerate a diaper change without physiological compromise. And for the purposes of our research, that's typically when we would start with the baby. So when they're able to tolerate a diaper change, we can actually do, even if they're still intubated, the Preemie Neuro, and we'll talk a little bit more about that shortly. And then finally, there's an expanding repertoire of tools available as the infant's medical factors resolve and as postmenstrual age advances. So as a baby gets closer and closer to discharge or term equivalent age, we're able to do more and more things with them in terms of assessment. So the neurobehavioral assessment, I wanted to take just a little bit of time because I think that there's varying opinions regarding a neurobehavioral assessment, and some really think of it as a procedure, and I like to think of it as an interaction. In fact, there was a neonatologist who approached me at Graven's a couple of years ago and was saying, why are you doing all those assessments with those babies? They should just be held by their mother. And I do agree that babies should be held by their mother, but the unfortunate piece of it is that in our NICU, we have a lot of mothers who don't visit, and so the babies are there by themselves in a room and many times lack appropriate interaction, except for, of course, the nurses come in and they do their cares and interact with them. But I like to think of the assessment as actually being an additional interaction that can actually be very positive and therapeutic for the baby. And with that, it's really important as an examiner to gain fluidity in how you approach or how I approach the baby. So like when I move them into different positions, like not fumbling through it and bouncing the baby around, but more so making it be very positive and smooth and doing things in order so that it minimizes the amount of changes that a baby has. And, ultimately babies in the NICU get a lot of negative exposures. They get heel sticks, they get intubated, and there's a lot of learning that happens from these negative exposures. So I think actually doing things like an interaction related to a neurobehavioral assessment can be positive in that, you're doing gentle movements and fluid things where you're putting the baby into different positions and testing reflexes, and there's no heel stick or anything associated with that. It's just an interaction, a touch, and ideally, it would be great if they had learning and memory associated with that, where they realize that it's okay. It's okay to be handled, and hopefully then they can increase their tolerance of it as well. So I like to think of it as an interaction and not as a procedure. So along with doing neurobehavioral assessments, there is a progression of tolerance of handling that definitely our team appreciates, and that there's potential physiological compromise with any handling, usually very early on. So always having that heightened awareness of that in a very immature baby, you don't want to be doing an assessment where it could potentially cause physiological issues. Also being very aware of motor stress signs that typically follow as they move down the continuum of development. Usually then they're able to tolerate short periods of handling with some compromise to their states of arousal, and then have increasing periods of alertness and tolerance of handling as they get closer and closer to term equivalent. And then ultimately, by the time they're discharged, typically they cope with those environmental stressors or interactions, and they're still able to continue to engage in interaction and be able to feed and do all the things that they're supposed to. So I think just looking at the typical progression of tolerance of handling helps you somewhat choose the tools that are appropriate as well, and that you wouldn't want to do a comprehensive assessment that's 20 minutes long on babies that were still in those early stages of being able to tolerate handling. Why are assessments in the NICU important? So we do know that there's more and more evidence surrounding the fact that preterm infants and also infants with high risk that are admitted to the NICU have high rates of developmental challenges, and that these developmental challenges typically continue throughout childhood. And the types of developmental challenges that are being identified continue to expand. So it used to be that we were very focused on motor outcomes, cerebral palsy, which is actually fairly rare in the broad scheme of it, but motor challenges, also cognitive and language impairment, But now literature is showing more and more that there's other more subtle deficits that are common in preterm infants, and that can include social issues, having sensory processing problems, having learning challenges, and the list of things related to preterm birth go on and on and on. Also, another reason why assessments in the NICU are important is that many times there's a period of time in the NICU when medical factors have largely resolved and the babies overcome the medical challenges that would keep them from being able to have a neurobehavioral assessment with targeted interventions, which allows for the perfect opportunity to get started with that. And along with that, many of them can tolerate those targeted interventions in the weeks leading up to discharge, and that also sets a foundation of the parents knowing what they can do with them as they leave the NICU. And then finally, there's this rapidly changing brain development that's occurring within the NICU environment, and this really provides a window of opportunity that makes those sorts of interventions that are targeted at trying to optimize outcomes so incredibly important. So there's been a lot of attention on early intervention programming, and that's why we have early intervention programs in every state now. It's a federally mandated program for children birth to 3, and it's really surrounded with the premise that there's this window of opportunity where we can really make positive changes in a child's life that will support them throughout their life. So it's a window of opportunity where the child's brain becomes wired, and early stimulation sets the stage for how children will learn and interact with others throughout life. The other part is that good or bad experiences affect that wiring of the brain and the connections to the central nervous system. And then stress results in increased cortisol, and this can cause brain cells to die and also reduces connections within the brain. So while early intervention programming is extremely important from birth to 3, the time within the NICU is being pointed out more and more as a critical period of development as well. And this is because there's this rapid brain development that's happening, and those are also evident in the amount of behavioral change that babies are making. Ooh, the first one's a little fuzzy there, but we'll just talk through this for a minute. So this is one of my favorite slides to show regarding, it's basically our evidence that significant brain development is in fact happening. So this is an example of the amount of cortical folding that happens across time when you're born preterm until your term equivalent age. So at 25 weeks, if you're born at 25 weeks gestation, the brain is fairly smooth. Then by 30 weeks, the cortex folds in on top of itself, increasing the amount of area that's available for higher order functioning. By 33 weeks, it folds on top of itself even more. And then by term equivalent age, it does not look anything like it did at 25 weeks. So substantial brain development is actually happening right before our eyes in the NICU. And this amount of cortical folding is actually more significant during this time from preterm birth until term than it will be at any other point in an infant's lifespan, as you can see by looking at this picture of adult brain, which looks more similar to that at term equivalent age. So we know that babies have significant brain development during the time that they're in the NICU, and actually the evolution of developmental delay, there's evidence to support that it's already present by the time that they leave the NICU. It's not something that they're developing after discharge, and so therefore giving a little bit more ammunition to the importance of evaluating and starting targeted interventions before they leave. So in our work that was published a couple of years ago, we compared the behavior of preterm infants that were born less than 30 weeks gestation to that of full-term infants. And what we found is the cohort had poor neurobehavior and multiple domains of function, which included they had poor orientation, poor tolerance of handling, poor self-regulation. They had more suboptimal reflexes, more stress. They also showed more signs of hypertonicity as well as more signs of hypotonicity, and then had more excitability than their full-term counterparts. So already at the time that they're discharged from the NICU, they were showing this evolution of developmental challenges. Also, kind of going along with the significant amount of brain development that babies have when they're in the NICU, we did a study looking at the behavioral changes that babies have when they're born preterm in the NICU in the final 6 weeks of extrauterine life. So we looked at differences in behavior at 34 weeks postmenstrual age compared to term equivalent age, and we found that babies do have significant changes that occur in regards to behavior. So changes in motoric function included increasing hypertonia, decreasing hypotonia, and declining quality of movement. They also had changes in behavior, including increasing arousal, increasing excitability, and decreasing lethargy. And most of these kind of go in line with what we see with babies. They go from being very floppy, kind of molding into the surface in an extensor pattern when they're born very early. And then as they get closer and closer to their due date, their flexor tone starts to pull them up a little bit more, and they're able to have more anti-gravity movements. And then also we see babies going from having very poor arousal early in gestation, and then developing more and more times where they're able to stay awake to really engage, and really engage in feeding so that they can be discharged from the NICU. The only one that was a little bit harder to understand was that we did see declining quality of movement from 34 weeks to term equivalent age, but perhaps that's just more of a reason why targeted interventions could potentially help these infants that have high rates of developmental challenges and are going through a lot of change during this time. So we know that development in the NICU is not static. There's acquisition of medical factors and brain injury, and there's also a significant amount of brain development, and then as I was outlining, neurobehavioral changes. Understanding early development can allow us to have a better understanding of factors that can be helpful or harmful in the NICU environment, and can also equip the clinician with strategies to optimize development in the NICU. And some of those strategies may be purely environmental. They also could be therapeutic interventions, and then they also could just be ways to get families to engage and provide appropriate interventions to their baby through parent education. Assessments and interventions in the NICU do, however, need to be tailored to each specific infant, and it's based on a multitude of different factors, which include postmenstrual age at the time, medical status of the baby, also what their energy expense is based on the interaction that the therapist or nurse or whoever is doing something with them is doing, and how that might relate to their weight gain and their ability to go home. And then also other interactions that are going on in the environment. So as I was mentioning before, sometimes we have to adjust what we're doing based on the baby's day. So for example, we have eye exams on Mondays in our unit, and I never go on Mondays to do neurobehavioral assessments with our babies. So neonatal neurological exams and neurobehavioral assessments have some factors in common. Neurological assessments typically look at muscle tone, reflexes, quality of movement, and neurological signs, and also neurobehavioral exams do as well. However, the neurobehavioral exams have a greater emphasis on orientation and attention abilities of the baby, also self-regulation, and then signs of stress. I also like to weight basically what I'm seeing when I do neurobehavioral assessment against what we would expect of a normal full-term baby. So it's always nice for me to be able to go back to do an assessment on a full-term baby also, just to kind of readjust my thinking of what is normal. So for normal newborns, we expect them to sleep most of the day but wake for 8 to 10 feedings per day, cry to indicate their needs, self-soothe, bring their hands to mouth, hands to midline. They also have physiological flexion at birth with flexed hips, knees, and elbows with shoulder horizontal adduction. They have relaxed tone at rest. They actively extend their arms with a return to flexion. Their movements are mainly non-purposeful. In prone, the infant raises their head briefly, holds their head in line with the body when pulled to sit. Sorry about this ambulance. In supported sitting, they can right their head in midline, and in standing, they support their weight, but they do stepping. And then for attention, a full-term baby can visually focus and track, and then also shift their gaze to auditory stimulation. So one of the things that I oftentimes will see is that we oftentimes compare neurobehavior across different babies within the NICU setting. So this 23-weeker compared to that 30-weeker. And for me, sometimes I often see even in my own thinking drift where I say, oh, this baby actually looks pretty good. And potentially they do compared to all of the other babies I see. But just being able to pull it back to gauge it against a full-term newborn is really beneficial. So we're actually going to enroll a full-term cohort within the next month, and I'm really excited to be able to see our normal full-term development to help myself kind of calibrate myself back. I wanted to just break down the neurobehavioral exam, and I think the easiest way to do this is to break it down into 3 main areas that we look at, so self-regulation, motor, and attention. It's kind of how I'll approach it. So self-regulation is the way that the baby is able to cope with all the demands of the environment. It's their capacity to soothe him or herself when stressed, and then just how they're able to cope with the things within the environment, and then continue to be able to do all of the things that are important, like feeding. So some of the things that we might observe during an assessment or even just during an observation period are stress signs, irritability and excitability, and then also adaptive responses. State regulation is very important because it affects other areas of function. The ability to assess other areas is also state dependent. So we don't assess a baby that's actively crying because their tone is going to be different, and also because we should be focusing on the baby crying. But the tone will be different if they're crying. If they're in a deep sleep or a light sleep state, their tone will also be different. So the ideal state for a baby to be in during an assessment is a quiet, awake state. And especially for orientation, that's the ideal state for them to be in. Some of the other things that we might observe is how they transition from one state to the other. Is the infant able to maintain an awake state, and for how long? And we also look at baseline posture and movement. I'm sorry, we're going to talk about posture and movement in just a moment. But, and this kind of alludes back to what I was saying before, in that if you're trying to assess a baby's tone, if they're in a crying state or a sleep state, you'll get a different picture than you will in quiet awake. So it's really important that we tend to the state of a baby as we're doing other components of the neurobehavioral assessment. There's also a relationship between self-regulatory abilities, motoric function, and behavior. So now baseline posture and movement. Some of the things that we'll look at are active and passive tone. And so active and passive tone refers to the contractile state of muscles, so like how tense they are within their muscles and how fluid, and that will affect how fluid their movements actually are. There's a lot of different things that we can tell. One, how they look when they're moving actively, and then also how they look when you're passively moving them. There can be differences in the upper extremities compared to the lower extremities. One of the most common things that we see too is where there's increased tone in the extremities, but then in the trunk there's low tone. So there's a lot of different things that we can look at in terms of tonal responses. And then posture is another thing that we'll look at. So without even doing anything to the baby, just seeing what kind of posture they hold their body in. So it's, they usually at the very beginning of the assessment, just for like 3 minutes even, watching how they move against gravity, and if they're holding themselves in physiological flexion, if they're extended and meshed into the surface, if they're doing arching. We can also look for head turn preference and just how they mold into the bed in the NICU. Also look at quality of movements. And so quality, how fluid they are, what kind of arc they get with the movements that they do, and then also the quantity. So isn't there an increased quantity where they're thrashing their arms or their legs around, or are they more calm and purposeful, like in terms of bringing the hands to midline or to mouth? We also look for tremors and clonus. Spontaneous movements, we can see if movements are cramped or fluid, jerky, and also if they have a hyper-startle response, where every movement brings about a startle response, which can also be very difficult for the infant to feel comfortable in the movements that they do. And then also we can look to see if movements are dominated by reflexes. So are they somewhat stuck in an AT&R pattern and having a difficult time pulling out of it? In terms of motoric functioning, one of the things that I get asked a lot is, well, why assess reflexes? What is really the importance of them? And I like to think of them as being really the foundations of early development. The reason why they're there is very important, and that they're foundational for later things that are to come. And it's the infant's way of showing these precursors to developmental skills later on. Movement progresses from primitive reflex patterns early on to voluntary controlled movement. Reflex patterns subside as balance, postural reactions, and voluntary motor control emerge, and low-level skills are prerequisites for certain high-level skills. Reflexes also help with balancing out flexors and extensors, and this can be really important for having fluid movement later on. And also just in terms of posture and quality of movement, if infants are doing a lot of increased extension, they can lose range of motion over time, which then can affect their ability to really engage in meaningful activities later. And then the third one being attention. So when we look at attention, and also another name for it being orientation in high-risk infants, we can look at habituation, and so habituation being the way that we tune things out that aren't important within the environment. So one way that we assess this with one of our tools is where you shake a rattle during sleep and they respond, but then they learn that it's not going to harm them, and so they tune it out. So habituation can be really important for babies as they go home, because a baby who doesn't habituate well can have difficulties and challenges sleeping, because they startle or rouse to anything going on within the environment. We also can look at arousal and lethargy, look at excitability, and then we can look at orientation. So how well the baby is able to visually attend to a caregiver, for example, within the environment. Focus on them, follow them. If they have a preference to one side or the other, if you have to approach them away from midline, or they're able to just engage reciprocally as well. And then there's a complex interaction between attention, motor function, and self-regulation, so we can attend to that. So the larger picture is that neurobehavioral assessments are, depending on which one is used, some of them are very short, some of them are very long, and include a comprehensive assessment of a multitude of different things. But as an assessor, I oftentimes am not necessarily looking at one little thing, like the specific response to what I'm doing, but instead looking at the overall picture of what that means for the baby. So we can tell a lot about asymmetry, like if reflex patterns are more prevalent on one side of the body compared to the other, if they have increased movement or increased tone on one side, that becomes very evident within a neurobehavioral exam. Also being able to tell their tolerance to the handling of the neurobehavioral assessment itself. Some babies have low perception, others are hyper-responsive. And then also we can tell some about coping too, like how well they're able to cope with the handling that is involved with a neurobehavioral assessment. And then we can also look at other responses, so startles, tremors, tonal pattern changes, also look at stress signs and how they cope and how they pull themselves back together, and then reciprocally if they then show approach signs thereafter. And then we can also see what their level of arousal is. So does it bring them to an awake state, and then how long did they sustain it, and then did they fall back asleep, and within what period of time? There are also skill-based assessments. So if you think just about what babies do, the typical things that we identify as their occupations are sleeping, feeding, and interacting. And all of the component skills of a neurobehavioral exam are somewhat represented within each of these domains of function, and that sleeping is very much related to habituation, their behavior, also self-regulation. Feeding has ties to motoric function, also self-regulation and behavior, and interacting to self-regulation, visual and auditory skills, as well as behavior. So there's a whole multitude of assessments that are available to assess development in the first year of life. The Doobly Width Practical General Movement Assessment can be used through the first 4 months of life. The ones that we really hear a lot, probably the gold standard being the Bailey Scales of Infant and Toddler Development. They're now in the 3rd edition of that. That gives you several different domains of function, which include cognitive, language, and motor. Also, the Peabody developmental motor skills, and the InfoNib can also be used in the first year of life. And there are more as well. But these assessments, some of them do say that they can evaluate at 0, from 0 until whatever, 12 months or whatever it is that they go up to. But a lot of the issues with using assessments that go through that first year of life is that they don't necessarily discriminate function very, very early, like in the neonatal period, which is what we work on. So because of that, we have to use tools that are specifically designed for high-risk infants. And then when they come back for follow-up, we switch to an assessment tool that's appropriate for the developmental stage that they're at that specific time. So just some of the neonatal assessments that are out there. Ones that are considered neurological include Practals, the Hammersmith, which is also called the Doobly Width, and the Preemie Neuro. And then neurobehavioral assessments include the NICU Network Neurobehavioral Scale, the NBAS, the APIB, and then also more recently the NAPI. There's also assessments that are purely observational, and those include the naturalistic observation of newborn behavior and the infant behavioral assessment. Also, Practals, general movement assessment, is purely observational, but it kind of falls in both categories. And then there's also the TIMP, which is more so used as a motor assessment, but there are some behavior items within that as well. So looking at all of these, what we do as a team is really look to see what is it that we really want from an assessment. Do we want it to be purely observational? Do we want to actually do things? Do we want a comprehensive assessment? How long do we want to take? Do we have people who are trained or can get trained in specific examination tools? And then you have some options based on what the answers are to those things. And these are just some additional information. Some additional information on different tools that are available for high-risk infants, which outlines a little bit more about the training that's required. So as you can see, the APIB requires a certification process. And then the NBAS and the ENDS also require a certification process, whereas the Hammersmith or the Doobly Width, you can self-train yourself with a published guide and a pro forma. There's now a book actually on it as well. So some of them require certification while others do not. So I wanted to talk a little bit about an evaluation that we use for infants that are medically fragile or very young in gestation or maybe even are still intubated, and that we did a lot of research when we first started our investigations to try and find tools that were appropriate. And we wanted to try and get at early neurobehavior, but not with doing a lot with the baby because we figured it was it wouldn't be appropriate very early in gestation. But we ran across the Preemie Neuro, and that's actually one that we use very early for our babies. So the Preemie Neuro is designed for infants between 23 and 37 weeks postmenstrual age. There is an abbreviated form that's available for infants that are less than 28 weeks postmenstrual age and or are still intubated. And so the abbreviated form means that you don't move the baby into all different sorts of positions, but instead the baby is just laying flat. There's actually 8 things that you do with the baby, and then the rest are related to observations that you make based on their posture and tremors and color changes and other things that you might be able to observe just from watching them. The abbreviated form only takes about a minute to do, and then there's also a full version of it that you can use if they're greater than 28 weeks and off of mechanical ventilation. And it takes less than 5 minutes, probably more in the range of 3 minutes to do. It has an additional 8 items where you do get the infant into anti-gravity positions. And then the other thing that I really like about the Preemie Neuro is that it scores the baby based on what you expect their performance to be at a specific postmenstrual age. So rather than grading everything on what you would expect of a full-term infant, it grades you on what they would expect of a baby that's at 30 weeks or a baby that's at 34 and so forth and so on. And then you get a total score from the Preemie Neuro, and then that can be converted to a categorical score where it says that their performance is normal, abnormal, or it's questionable. The other one that we use is the Doobly Width or the Hammersmith, and this is one that's been around for quite some time. It's for infants at or around term age. It takes about 10 minutes to administer. It requires moving the infant in non-supine positions, so you do get them up and sitting, and then also in ventral suspension for that one. It has 34 items, and each item is scored as 0, 0.5, or 1. So you end up with a maximum score of 34, and then there's published literature on the fact that they've come to 31 as being a cutoff for babies being considered suboptimal. And this is all in this article that I put here, an optimality score for the neurological exam of the term newborn. There's also some differences in scoring that you would use if infants are between 36 and 40 weeks, so that everything isn't necessarily graded on the performance of a full-term baby. And that one does not require a training process. The other one that we use is the NICU Network NeuroBehavioral Scale, and this one is a comprehensive assessment. It's 115 items. About half of them are things that you actually do with the baby, and then the other half are observations that you make throughout. It gives you tons and tons of information, though, so it comes in the form of 13 summary scores that include quality of movement, non-optimal reflexes, self-regulation, attention, excitability, asymmetrical reflexes, hypotonicity, arousal, hypertonicity, handling, and lethargy. And so you get scores from this one, and then just a lot of information. It's set up in assessment packages to try and minimize the amount of handling that you give the baby. So everything kind of goes in a specific order. It does require a certification process for that one as well. So understanding early development can allow a better understanding of factors that can be helpful or harmful It can also equip the clinician with strategies to optimize development, and those can be environmental, therapeutic, or just helping parents better understand what they can do with their babies. So some of the items that we can assess that are contained within these neurobehavioral exams are things that we do to the lower extremities that can include things like plantar grasp, Babinski, lower extremity recoil, popliteal angle, heel to ear, or lower extremity traction. Also things that we can assess the upper extremities, which can include scarf sign, upper extremity recoil, palmar grasp, upper extremity traction, and then also if we move on to the face, looking at rooting and sucking. Other things that we do more to the core relate to looking at truncal tone, how they do with pull to sit, if they can do head writing, placing, bearing weight on their lower extremities, stepping responses. We look to see what their tone looks like in ventral suspension, and then we can look at incurvation or the gallant. In prone, we can look at how they raise their head in prone, and also if they demonstrate spontaneous crawling, which is more of the precursor to crawling, so it's more of these primitive responses. Also, just holding a baby in your arms can tell you a ton about their tone and their interaction, whether they hold themselves stiff as a board or if they participate and turn in. Also look at how they do with auditory orientation, so how they respond to a voice, other noises within the environment, or some examinations also use a rattle, and then also how they respond to visual things, so how they respond to a human face in front of them or a human face talking, and can they follow that side to side or horizontal or in an arc, vertical or in an arc. We can also look to see if they have defensive responses, ATNR or Moro. And while we're doing neurobehavioral assessments, we can make a ton of observations, so looking to see if they startle, if they tremor, what their quality of movement is like, if they have stress signs, posturing, asymmetries, coping skills, if they transition immediately from one state to the other, showing that they don't have good state regulation, if they avert their gaze, if they have nystagmus or irritability, fatigue, color changes, consolability, thumb adduction, back arching, or crying. So in conclusion, early neurobehavioral assessments are helpful. Early behavior that we're able to learn from the baby is meaningful. There are a lot of standardized assessments that are available for assessment in high-risk infants. However, each does have to be chosen extremely carefully based on the population, the postmenstrual age that it's intended to, also what domains of function you want to get, and then also if you want it to be purely observational, or if the baby is able to tolerate actually doing more physical assessment. A normal examination in the newborn period is reassuring, but there are a lot of infants that end up scoring abnormally on neurobehavioral assessment, and they may show later recovery. And so we're continuing to do research to try and untangle if we can try and predict the ones that will go on to do better, and also potentially how the environment after NICU discharge may impact this recovery process. Kathy, could I turn it over to do a quick video?
Yeah, absolutely. So I'm just going to flip the screen. Can you hear me now?
Yep, we can hear you, Kathy.
Okay, great. Just wanted to make sure before I... So we have a couple little snips of a video that we want to show, and Bobbi's going to narrate those as we go through. And I just want to give the warning that, of course, video is always dependent on everyone's connection speed. And so you may be out of sync at times with exactly what she may be saying. So we're going to give you a link, and I'm going to put it in the chat area right now, where you can actually download the video. If it may go faster if you put it in a secondary screen. But we're going to go ahead and show it, and then allow Bobbi to narrate and kind of describe the the actions. And again, we'll leave the link in the resource area, but I just always want to warn people that, you know, what we see may not always be what you see, maybe a few seconds behind and even up to 30 seconds behind, depending on the speed of your connections. So I'm going to switch it over really quickly to screen sharing. And the first video is here. So I'm just going to back it up to the beginning.
And then I just wanted to give a little caveat. So these are students that are in our lab right now who put this together for me. There are some things that are ideal, and then there's other things that aren't. They are actually new to the whole process of learning about neurobehavioral exams. So I'll point out some of the things that they are able to show, and then also what we may be able to observe as a clinician based on what they're doing, and then also try and point out things that I would have changed too.
So would you like me to play the first one?
That would be great. Thank you.
Okay.
So the first one is plantar grasp. That can be done just while the baby is laying in supine. You take a finger and you place it on the pad of the baby's foot. And the normal response is for the baby to curl their toes around the examiner's fingers.
Are you ready for the next one? You want me to go back and show a picture?
I didn't see it, but it could just be the connection speed of my own computer. So no, that's fine. So one of the things with the plantar grasp too, there it is that for the student that's demonstrating this, she has her arm or her hands wrapped around the baby's leg. So I would have minimized the contact made to the baby's leg so I didn't impact the reflexive pattern that I saw in the baby. You're also able to look at this one bilaterally, so you can see if it's stronger on one side versus the other, or present or absent on one side versus the other. Yep, I'm ready for the next one.
It says Babinski reflex.
Okay, and then the Babinski is done by stroking the side of the baby's foot from the pinky toe down towards the heel, and then you look for the big toe to extend and the rest of the toes to follow, and then for it to relax. So some babies that have tonal abnormalities have a sustained Babinski where they just stay in it all the time, and usually with that very, very tight ankles. Other times they just don't respond, and you can also look in this in each leg so that you can look at asymmetries. And then the next one. The next one is ankle clonus, where you just do a quick movement into dorsiflexion, and then you're looking for a beat of the muscles. So some babies that have neurological problems, they can have sustained and prolonged, so they have prolonged and then a lot of beats of clonus. It's okay if a baby has a couple of beats as long as they continue to dissipate, and usually around 4 or 5 is what we like to not go beyond to view this as a problem. You can also look at it in each leg to see if there's differences in each side. And the next one. And then the next one is leg resistance.
Pretty quick.
And actually my computer isn't even showing it, so I'll just go ahead and hope that everyone else can see it. So the next one is leg resistance, which is coupled with recoil. So full-term birth, babies are born in a nice flex position. If you pulled their leg out into extension, it would spring back into flexion. You can also see if a baby has increased tone just in the process of pulling them down into extension. But you would just pull them down and then look to see how they spring back. Also, if one leg springs back versus the other, you can look for that as well. And the next one.
And just so everyone knows, I'm pausing them. I'm kind of like playing them, going back and pausing on an image. So you may see it kind of stopping and starting. So I'm hoping that's helpful and not distracting. So next one is power of active leg movement.
And then power of active leg movements is not so much something that you're stimulating. And in fact, it's done with a lot of excursions here, which I probably wouldn't have done. It's just more of trying to see how much resistance you can place on the baby's leg, like so how strong, how much strength that they can overcome the movements that you're placing on their leg with just an index finger and your middle finger. You can look at that on both sides as well. And the next one. And then the popliteal angle is done by bringing the knee up towards the chest and then increasing the angle underneath of the knee until the point of resistance. And with this one, probably the biggest error, if you want to call it an error that I see, is the thinking that this is a test of how much range of motion you can actually get, when in fact it's just coming up to the point of resistance, and then that's where you stop. So a normal full-term baby will have about 90 degrees in that angle underneath of their knee. The babies who are hypotonic or even early in gestation will have an increased popliteal angle. And then many times kids that have neuro problems or have tonal abnormalities will have very low, below 90 degrees. And you can also look for asymmetries with this one as well.
The next one says scarf sign.
And so those are the ones in the lower extremity, and then we move up to the upper. Scarf sign is taking the arm and wrapping it around the baby's neck. That sounded worse than it really is. But you bring their arm in horizontal adduction. And this is going to tell you a lot about shoulder tone, because babies who are in the NICU for a long period of time and mold into the surface tend to have tight shoulders because they've been pushing back into the bed for stability. So those babies will not be able to even bring their arm across their chest. The elbow coming to the in between the two nipples is a normal response, and then our hypotonic babies, you can wrap it almost completely around their body, and then the hypertonic babies not even being able to get their elbow to midline, and you can also test that in both arms. Next.
Next one says forearm resistance and recoil.
And this is very similar to the lower extremity resistance and recoil, where you pull the arms down into extension. You can feel for resistance or how tight they are, and then you let go, and you would expect a normal response for the arms to spring back into flexion. And you can look at both sides as well. And then the next one.
Next one says power of active arm movement.
And then same thing here. We would just be looking for the amount of resistance that the baby could overcome. Just using an index finger and a thumb. And then next. And also one other thing, I meant to point this out earlier, is that during neurobehavioral assessments, it's really important that the baby doesn't have a pacifier in their mouth, because that can affect their tonal responses. So it's ideal if that is not in their mouth.
Next one is rooting.
Then rooting, you put on a gloved finger, and then you're going to stroke the side of the mouth, looking for the baby to sense the stimulus and then turn their head and try and grasp onto the finger. You can also do that on both sides. And then you can turn straight from there. You can turn the finger up, and you can check for sucking on your finger to see if there's a burst pause pattern. And then also if they have good coordination in between suction and compression. And next.
Next one is sucking.
And then I think you can just keep going.
Okay. Grasp of hand.
And then you're just going to take your finger and you're going to put it in the baby's hand. It's ideal if you reduce the amount of contact anywhere else. So, for example, I would have moved the left arm away from the baby's arm and just put my finger in the baby's palm, and what you want is for them to grasp. So close the fingers around your finger and then to release it within a couple of seconds. And you can also look at that on both sides.
Next one is truncal tone.
And then truncal tone is basically the start of then doing more of these positions and movements where you get the baby up. So here you would lift the baby up off of the surface and try and fold them to a certain extent. This can tell you a lot about how what their truncal tone looks like. So some babies will just stay in a stiff board. Others are very hypotonic, and you could practically bring their feet up to their face if you were to go that far. But instead, you're just trying to see how much truncal tone they have when you try and fold them. And then
and the
when
hand position. Oh, sorry. Is the hand position? Do you have any comments on where the student has their hands in this one?
Oh, yes. So actually, the hand placement on the right side would be better up on the rear end because you're actually not flexing the feet, but instead you're trying to flex the trunk. And then, yeah. And then while we do truncal tone, we're just then thinking about what's the next one, and the next one is pull to sit. So while we do truncal tone, we would be putting them in the position that we would want in order to do pull to sit. And then pull to sit, we're just going to take the baby's arms and pull them up into a sitting position. So from going from supine to sit, some infants require you to put the hand behind their neck so that you can give them a little bit of support and at least having that extra safety net there. But you're looking to see if they hold their head in line with the rest of their body, and then when they come up to sitting, if they're able to right their head. So if they pull themselves into flexion of the neck, can they right their head back up into midline? And you can also look at specific patterns, like if they have more extensor tone or flexion tone or a lot of different things kind of mixed in with this writing response. And then we pick them up and we do placing. In this way, we turn them away from us. And the stimulus should be on the top of the foot. With this one, the student should have had the baby tilted a little bit more to one side, so you only stimulate one foot at a time. But stimulus on the top of the foot, and you want to see the leg lift up into flexion and then go into extension to place down in preparation for stepping. And then we do stepping right after that. With stepping, you just put the baby in a position of standing, well, supported standing, of course, right, because they're not going to run off the platform. And then you want to see reciprocal flexion and extension of each leg. They should usually do about 3 steps before it stops. And then straight from here, you can put them into a ventral suspension position where they dangle over a hand. And you can tell a lot about the tone in the trunk. So do they flop completely over your hand, or do they increase into a lot of extension? And then straight from there, you can do gallant or incurvation, where you take a finger and tap just to the right or the left of the spinal cord, and you should see the baby's entire trunk flex on the side of the stimulus. I think that the student went backwards in this video, but it's really, you should go from top to bottom and then be a little bit closer to the spinal column on that one. And then straight from there, you can just bring the baby down into a prone position. And what you want to do is see them lift their head to clear their airway. So usually I'll come down and just talk to them to try and get them to lift and turn their head. I think in the video the student actually lifted the student's head, but we don't do that. You can also look for crawling movements, and if they don't do it, you can just give them a little stimulation on the bottom of their foot to see if they'll do some crawling movements. Then we pick the infant up and hold them in our arms to see how they mold into us and how they respond to that interaction. Likewise, then we'll put them on a shoulder. And then what do we have next? Did she do orientation?
It's still, I paused it on the cuddle.
And then right after cuddle, does she have orientation?
Orientation.
Usually we do orientation right after this because that's usually the time where the baby has now woken up from the handling that's been done, which makes it the perfect time to be able to do orientation and assess how they're doing. Usually the baby goes in your lap, though, and then you start using your face, typically, calling the baby, seeing if you can get them to look at you at midline, and then going side to side, then vertical, and then into an arc. You can also use different stimuli, your face with voice, a rattle, a red ball, and then you can also do auditory orientation too, where you're just on the side of them and you're calling their name to see if you can get them to turn and look at you. And then the exam finishes with 3 final items, and those are defensive, AT&R, and Moro. I'm sorry, and actually we can skip over tonic deviation because that's kind of an interesting one in and of itself that we don't usually do anymore. And then for defensive movement, you would put a diaper or a cloth just above their nose so that you're not occluding any of their air exchange. And the baby should perceive it, and then they should lift their arm up to remove the stimulus. And this can tell you a lot about tone, too. Sometimes you see babies perceiving it, but they just can't quite get their arms up there. Some babies will just fall asleep. So there's a lot of different observations that you can make from that one. And then we do AT&R, where we turn the head side to side to look at associated postural changes. And then we finish with the Moro response. And so with the Moro, you hold the baby in your arms and you drop them down just about 15 degrees, really. You want the arms to go out into abduction and then to smoothly come back to midline. And that can tell you a lot about asymmetry and then also just whether they have that protective response.
Great.
So hopefully this gave everybody at least a little bit of an overview of the NeuroBehavioral Assessment. And thank you so much for taking the time. And I'll look forward to hearing if there are any questions or comments.
Great, Bobbi, thank you so much. That was really jam-packed with information. All through your talk, you've had many questions on the sides in the chat area. So if you have a question now, please feel free to put it in the chat area. But in the meantime, Kathy Randall is going to try to facilitate asking some of the questions that were already up there.
Yeah, there was just a lot of side conversation too about just the importance of skin-to-skin care and some of the barriers that we face in the NICU, on an ongoing basis. I'll just kind of maybe start at the end and move. And if people want to reiterate their questions from earlier, that would be fine too. So all of the assessments that you showed during the video, I think this one popped up while you were doing the video. Are they based on corrected gestational age? All of these assessments are based on gestational age of the infant, correct? You'd expect a 34-weeker to have some flexor tone over a 28-weeker who I wouldn't necessarily say the 34-weeker would have excessive tone. So
yeah, and I think that's a really great question. Yeah, and always, I think we have in mind that behavior is going to be different across time, that it's not just a static thing. Some evaluations are better at differentiating or even having expected scores for babies at specific postmenstrual ages compared to others, while others are just kind of gauging it on a full-term baby, like what is an expected performance, where you would expect for the baby to have more, what would be the word, more alterations in early behavior, but that it should kind of start closing in and getting closer to what a full-term infant is as their postmenstrual age advances. But yes, they all are with corrected postmenstrual age in mind.
Great. Someone had a question about a tool that you didn't mention that their hospital is using called the Emil Tyson tool. And I don't know, it says, are you familiar with that? And if so, what do you think of it?
Yeah, so the Emil Tyson has actually been around for a really, really long time. I think it's actually one of the original tools from way back when. It's not one that we currently use. We actually use more ones that have, they probably have a lot of the same sorts of things as the Emil Tyson, but they are not the Emil Tyson. So since I don't use it, I guess I can't really comment too much on it.
Okay. There's just a question about suggestions on educating management and the importance of this, and funding dedicated time to provide these, and then how do you what tools could someone use to prove its value to management who's maybe being resistant?
Yeah, I think that it is sometimes it is a hard thing to get people to understand, and I like to go back to like what we do with adults. So if an adult has a stroke or a brain injury, we do formalized assessments, and then we do targeted interventions to try and deal with those. But for some reason, when a baby has a stroke or has a brain injury, the approach is very, very different. And even at discharge in our own hospital, there's the recommendation for early intervention, but sometimes it's just very, loosely recommended, and maybe not necessarily stressed as being as important as it would be if it was an adult. So I think that education can definitely go a long way, and then if there's some way that you can track your own outcomes, where you can actually see what behavior is when they're leaving the NICU, and then potentially in your follow-up clinic, if you have one, what percentage of your kids are going on to have developmental challenges, that can also be ammunition for being able to better use neurobehavioral assessments early to then inform the interventions that could have optimized that outcome.
Awesome. Someone is asking, so while you're performing the assessments, do you do it with parents or other NICU staff present so that they're able to do some teaching and understanding of maybe that individual infant strengths or areas for, like you said, targeted interventions?
Yeah, and unfortunately, most of the time when I see our babies, the parents aren't there. We're in an urban area, and parents have challenges to coming in. But having said that, when a parent is there, it's preferred that they're actually right there and observing and asking questions as we go along. And I think it's actually a wonderful way to get them to see all of the different things that a baby does. Many times, we just have them wrapped up and we unwrap them to do their diaper change, and then they're wrapped back up, and so they don't necessarily know all the amazing potentials that their baby has. And so I think that it really is a good thing to do in front of parents when they can be there, because then they're going to be the primary caregiver, so the carrying out of therapeutic interventions is going to have the largest impact if the parent can understand what to do and carry it out.
Awesome. Maybe just the final one would be, there's some question about, can you clarify the declining quality of movement that you noted in your study as babies approach term? And would you be willing to give the reference for that study? I know that you talked about the study that you did, and a couple people asked for that reference.
Sure. So I don't know if I have a very good full understanding of what the mechanism was. We can speculate, but unfortunately we didn't really break it down to really know why that is. It was surprising that quality of movement decreased from 34 weeks to term. So my speculation is that when babies are born preterm, they have alterations in tone just from being immature. So the central nervous system isn't doing the same thing that it would do at term equivalent age. And so their tone when they first start out is low to begin with, and they're not really ready for an environment that has gravity. And so they're supposed to be in this buoyant, contained environment of the womb, and instead they're dealing with gravity. Their body is low tone. So it's forcing them into altered patterns of movement just from being born. And so potentially their quality of movement shows signs of alteration that you can't necessarily compare to a full-term infant. And also potentially as they try and gain active movement, I don't know, maybe it just, the quality according to this scale picks up that it's different. So I don't know if I have a great full answer for that, but I speculate that it has to do with gravity and alterations that are already ingrained that make it harder to acquire appropriate movement.
All right, so I lie. So one more.
Oh, and I'm sorry, there was a request for the reference too. I forgot. I'm sorry. So
yes.
one I
No,
believe,
okay.
so it's Pineda and Inder are the first and last ones on that one, and that's Journal of Pediatrics from 2012. I could also send it if there's a way to post it. I could do that.
Yeah, there were actually, I'll make a little note and send to you. There were a couple requests for some specific references from some specific slides, some stuff on the cortisol levels. I would guess some, like from my experience, I think some of the best stuff out there is the stuff that comes out of Sick Kids in Toronto from Ruth Grenau's group on cortisol expression and stress. I don't know if you have others in mind, but maybe we could just do a little quickie list and include it on the reference page or on the resource page.
Sure. Yeah, that sounds great.
So the final one, because I'm kind of nerding out over this question, so I kind of want to know the answer, is can you comment on a specific intervention for babies who have poor habituation? I thought that was a great question.
That's a great question. And probably, there's a lot of babies that have poor habituation that then have these sleep problems that we do need to kind of figure out. But I guess the question is, can we apply a blanket strategy to every baby that has habituation, or would it truly be individualized mixed with everything else that they're showing and doing, which I think it would be the latter. But, what are some potential interventions? I think that maybe some of the habituation problems that babies have in the NICU are related to having a lot of negative sensory stimuli, noxious stimuli, painful stimuli. And so if you're being bombarded by all of these negative things, you're going to have this heightened awareness and then have difficulty habituating even when things then turn out to not be so negative in the end. So probably showering babies like that with positive sensory stimuli in general so that they can get on track with realizing and integrating normal positive experiences, whether they be touch and auditory, vestibular, kinesthetic, across the board. So I think it's more of like probably a general approach that I would take.
No, I love that. That's great.
Thanks, Bobbi, so much. That really was a terrific webinar, and it did go well over, but I think every second was worthwhile, especially the videos, and hopefully you can all see them through the link that Bobbi gave you. This webinar was brought to you by DandleLION Medical, and we are so pleased that we have experts like Bobbi as part of our webinar series who are willing to spread their information. We do have several DandleLION products that may help with neuromotor development. The RU2 and the DandleWrap Stretch are made from a high-performance fabric that's really similar to the fabrics that are in high-end athletic apparel. The fabric is breathable and wickable and has a 4-way stretch, and the products help to keep babies contained and comfortable while also being in proper physiologic position and allowing them to stretch and move like they were in utero. So a lot of the movement is becoming increasingly important to brain development the more we learn about how the baby's brain is developing, especially those little tiny preemies. If you're interested in receiving more information or a sample of the RU2 or the DandleWrap Stretch, there's a place in the evaluation form where you can indicate your interest. In order to receive your free CE, you're going to need to fill out the webinar evaluation. In the chat area, you can click on the evaluation link, or once we're finished, you'll be immediately redirected to the evaluation form if your firewall allows. At the end of the evaluation form, you'll receive a link to the CE certificate. If you don't have time to fill out the evaluation right now, or your hospital has blocked access, you will receive an email within the next few hours or maybe even tomorrow with a link to the evaluation as well as a link to the recording and a PDF of the slides. If you're viewing this as a group, you must each log in to the evaluation form to get the CE. We hope that you'll visit the DandleLION Medical website to see our great products and also to learn about future webinars and links to the recordings. We now have 29 our previous recorded seminars, and those from the last 3 years are still available for the free CE. Hope you all have a great weekend, and thank you for your participation. And Bobbi, thank you so much again for your great information.
Thank you.